This evening, I'm going to bypass doing all the formalities of program orientation and housekeeping. I think you all know all the ground rules by now. This evening, we're going to be talking about endocrine disorders, non-diabetic related, joined by my friend and colleague, Dr. John Donnelly, and by Dr. Elizabeth Klingensmith, who is now a newly minted doctor. So welcome, doctor, to the fold. So John Donnelly, MD, FACP, FAAP, provides dedicated and compassionate care to his patients as a pediatrician and internal medicine physician, treating newborns, adolescents, and adults as part of his practice scope. He is also active in medical education, as this evening, working to train the next generation of physicians as a clinical professor of medicine and a clinical professor of pediatrics at the Sidney Kimmel Medical College at Thomas Jefferson University, part of the Christiana Care Network. Additionally, Dr. Donnelly currently serves as Director of Medical Education for Christiana Care's Department of Medicine. Dr. Donnelly earned his medical degree from Michigan State University's College of Human Medicine in East Lansing, Michigan. He completed his combined internal medicine pediatrics residency at the Medical Center of Delaware, Christiana Care Health System, and at New Moore's AI DuPont Institute for Children. There he served as chief resident and chief of service, respectively, during his final 2 years of the program. Somehow or another, our speaker from last week's in here. Sorry about that. Matthew Lynn spoke last week. Elizabeth Klingensmith was a fourth-year medical student at Sidney Kimmel Medical College in Philadelphia. And after graduation, which is now, she will begin her residency in internal medicine at Christiana Care in July. So she's on break right now. Enjoy it, my friend. And at this point, I'm going to turn it over to Drs. Donnelly and Klingensmith.
All right. Thank you so much, Tim. Tim, we hope that you are able to represent the Delaware Academy and Delaware Public Health Association at the annual meeting today. And we hope that you will be able to catch this content on the back end on the recording. So let me get this PowerPoint launched here. And then let me find the share screen. All right, you should be able to see the PowerPoint now. You got a thumbs up?
Thumbs up.
All right, we're in business. All right, so welcome everyone to the mini medical school. We're excited to be here as part of the curriculum, and thank you to Tim and Cynthia for inviting us to speak tonight. We were invited with a request for a talk on endocrinology, and neither Dr. Klingensmith nor I are endocrinologists, but we would really like to approach this from a sense of general internal medicine, as that is really the basis of what will soon be Dr. Klingensmith's training program and a lot of the work that I do in medical education. While you're waiting for us to get started here, please feel free to snap this QR code down here. That will take you to a quiz program, and we will have some quiz questions built into the program tonight. So let's talk a little bit about the endocrine system. And I think that the endocrine system is really overshadowed by the large organ systems in the body. The endocrine system is not as flashy as the cardiac system or as slick as the GI system. It certainly doesn't have the pizzazz of the nervous system, but really the endocrine system does some incredible work. The endocrine system produces hormones, and those hormones can regulate a number of processes, including metabolism, calcium balance, stress response, and many other things. And what we want to make sure that we represent is that those hormones require balance. And when there is balance, we think that those hormones are heroes that really provide incredible service to our body, But when that balance goes awry, then we feel that those hormones can really turn into the villains that can cause chaos and destruction. So we really would like to walk through some of the things that we've learned in medical school and residency to understand the function of a number of the glands in the endocrine system. So as Tim had mentioned, I'm Dr. John Donnelly. I'm a clinical professor of medicine, and my career has really been focused around medical education. I work very closely with medical students and residents here at Christiana Care, and it gives me a really great opportunity to see physicians who are growing up through their clinical education and learning how to become excellent physicians. And it gives me really opportunity to work with physicians like Dr. Klingensmith, who I had an opportunity to work with as a medical student. So, Liz, would you like to introduce yourself?
Hi, everyone. I'm Elizabeth Klingensmith. As was said before, I'm graduating from Sidney Kimmel Medical College this year and starting as an internal medicine resident at Christiana this summer. And I'm very excited to be here and talk about the endocrine system tonight.
All right. So tonight we have a number of learning objectives. We would like you to learn how the endocrine system uses feedback to keep hormones in balance. We'd like you to learn how the hormones and the function of the thyroid, the parathyroid, and the adrenal gland. We'd like to learn how the imbalance in the feedback system is what leads to disease and dysfunction. And we'd also like you to learn some of the common ways that medicine can treat endocrine diseases by resetting that balance. Again, if you have an opportunity, go ahead and feel free to snap that QR code to take you to the quiz that we will get to later. So if you look at the endocrine system, it's really a diverse group of glands and organs throughout the body. Some of the highlights in the endocrine system include the pituitary gland in the brain, the parathyroid and thyroid glands, which we'll talk about. The liver and the kidneys actually have endocrine function as well, and we will show how they interface with some of the hormones that we're going to be discussing. And then, of course, the adrenal glands and the ovaries and the testicles. One gland that we've left out is the pancreas, as we've been asked to talk about non-diabetic endocrinology. Diabetes is almost a specialty in its own, as that there's so many ways to address diabetes, to treat it, and the complications that can be caused by it. So really, we will not be talking about the pancreas much today. To start our discussion about the endocrine system, we want to make sure that we focus in on the pituitary gland. The pituitary gland is actually an interface between the nervous system and the endocrine system, and that interface happens through a structure called the hypothalamus in the brain. The pituitary gland secretes a number of hormones that then signal a lot of other endocrine glands on what they need to do. So when we talk today about the pituitary, remember that the hypothalamus is involved as well in that pathway, but we're really just for simplification going to leave the hypothalamus out of most of our conversation. And then we need to really define what the hormones are. So we've called these our hormone heroes. And hormones are often very unknown for many people on what they actually do. But what we really want to emphasize that hormones are a messenger system. It's a way that our body can get information from one area to another. We certainly know that the nervous system is a great way to get information, but there's a direct line from your brain and your nerves to where that message needs to go. But let's say that you need to get a message to someplace else, or maybe that message needs to go to multiple different tissues, and a hormone is a way to do that. So typically what happens is a gland secretes a hormone. That hormone then will go to another part of the body and go to those cells of the body and give those cells a message on what that cell needs to be doing. So the hormones of the pituitary gland, remember this is the command center, there are a multitude of hormones there, as you can see. We're going to talk about a few of those hormones in detail, and Elizabeth is going to put a list of different abbreviations in the chat so that you'll be able to see some of those abbreviations as we're getting to them and remember what some of these things are. The adrenocorticotropic hormone is produced by the pituitary and stimulates the adrenal gland. The thyroid hormone stimulates the thyroid. And the antidiuretic hormone we will also be talking about as that and the influence it has in the kidney and blood pressure. And we'll have a little brief mention of the melanocyte stimulating hormone. So no spoilers, but we do have some information on that. Now the endocrine system, to highlight a few of the glands there, the thyroid gland makes thyroxine, which is known as T3 and T4. So we'll teach you some of that. The parathyroid gland has a lot to do with calcium, and so we'll talk about that. We're not going to so much talk about the reproductive organs and the sex hormones of testosterone and estrogen today, as those really are almost a completely separate talk. The adrenal gland produces a number of hormones. We're going to concentrate on aldosterone and cortisol in that conversation. And we're going to talk a little bit about angiotensinogen as that comes from the liver. So we talked about the idea that there needs to be balance, and balance comes from feedback. And what's really interesting on our endocrine system is it often uses what's known as a negative feedback loop. And to really demonstrate how a negative feedback loop, I want you to think about your thermostat and your heater. So if you set your thermostat to a temperature, let's say you want it to be 78 degrees inside your house, and the house is currently 70 degrees. You set that thermostat to 78 degrees, the thermostat sends a signal to your heater. The heater then produces heat, and once that heat rises, that higher heat will then trigger the thermostat to shut off the signal that's going to the heater. Now, let's say there's a problem in that loop, though. Let's say the thermostat is broken and it's not listening to the instructions of the heater anymore. And once the heat goes up, the thermostat's not listening anymore, and it just keeps signaling the heater, make more heat, make more heat. Then we know that there's going to be a problem there. Or maybe let's say that the heater's broken. It's not getting that signal from the thermostat anymore, and it's not producing heat, even though the thermostat is telling it to. So I really want you to think about that as we go through these different endocrine systems, because there's going to be very, very similar themes on the way that the glands work. So for example, we're going to talk a little bit about the thyroid gland and the way it interfaces with the pituitary. We'll talk about the adrenal gland and the way it interfaces with the pituitary. They make hormones. So the hormone is made in one area, it signals another area that there's enough hormone, and that should send a signal to shut down the hormone production. So that's really where all that balance comes from. So balance is important, and if we have our heroes and they have balance in the force, and everything seems to be doing well, but we know what happens when they lose that balance, and those heroes will turn into villains. So why don't we go ahead, and I'm going to turn it over to Elizabeth to talk about the thyroid gland.
Okay, so our first endocrine organ is the thyroid. So this is your thyroid. It's found in the front, or sometimes we say anterior part of your neck. It's shaped like we say a shield or a butterfly sometimes. And we're going to talk about the anatomy of it. You can go to the next slide, Dr. Donnelly. Yep. So the thyroid is made up of different lobes. We have a right lobe and a left lobe, and a thin strip of thyroid in the middle called the isthmus that connects those two sides. And you may have heard that word before. It's a small piece of land that connects two different pieces of land, and that's exactly what it does in the thyroid. The other important part of the thyroid anatomy that's a little bit of a spoiler for later is that the parathyroid glands are very tightly bound to the back of the thyroid. More about that to come. So what does the thyroid do? Well, here we have a picture. It's called a histology slide. So it's a little piece of the thyroid under the microscope that we're looking at. And we can see all the different cells of the thyroid. One of the kinds of cells, the follicular cells that you can see on the slide, are the cells responsible for making thyroid hormone. We call them T3 and T4. Those are the two different hormones. And these hormones act all over the body. They affect our heart rate, metabolic rate, energy levels, weight. They can affect how our skin and hair feel, as well as bowel function. And how does this all happen? Well, it all starts in the command center, in the pituitary. the pituitary releases a hormone called TSH that tells the thyroid to make T3. T3 is converted to T4, which is really our active thyroid hormone in the body, and T4 goes out and does all of its functions. The other important part of T3 to T4 is iodine. And you may know this, most of our salt here in the US is iodized, which is done to promote enough iodine in our diet to make sure we have healthy thyroids. And in other parts of the world where they don't have iodized salt, having low thyroid function from low iodine is still a very real problem. So we have our T4, and T4 will go out and do all the functions of thyroid hormone. But when we think about our feedback loops, if we have a high T4, that's going to go back and tell the thyroid it's made enough. It can stop making T4. And it's also going to tell the pituitary to stop telling the thyroid to make hormone. So our feedback is going to go to both parts of this loop when we have enough T4. So let's talk about what can go wrong. We're first going to talk about low thyroid function or hypothyroidism. And let's start with our regular feedback loop, triggering the regular feedback. And what if the pituitary isn't working? It's not producing enough TSH. Then the thyroid is not going to know to make T4, and it's going to release low levels of T4. When we have this, we have our symptoms of hypothyroidism that we'll talk more about. But when we think about the feedback loop here, it really is kind of a moot point. Because our command center is not working, the feedback can't tell the command center to speed up production. So we really don't have a feedback loop in this case. This scenario is what we call secondary hypothyroidism. And when we look at patients' lab levels that present with this condition, we find they have a low TSH and a low T4 level. Well, let's consider another scenario. We'll start with our regular feedback loop. But now, what if the thyroid isn't working? We have a normal command center, but the thyroid is not making T4, or it's making low levels of T4. We're going to have identical symptoms as before, but now our feedback loop is really going to quiet down. And it matters now because this is going to tell our command center, our pituitary, to make more TSH. The pituitary is trying to tell the thyroid to make more hormone, but the thyroid doesn't work and it can't respond to that. And this is what we would call primary hypothyroidism. And when we look at our labs here, patients will have a high TSH and a low T4. Now, why might this primary hypothyroidism happen? The most common cause is something called Hashimoto thyroiditis. And this is really the most common cause of hypothyroidism in the developed world. This is an autoimmune disease, which means that there are antibodies that your body makes that attacks the thyroid and damages it, prevents it from making enough thyroid hormone. You can see here in this picture, the Hashimoto's disease thyroid looks angry and inflamed and like it couldn't produce or couldn't work properly compared to the normal thyroid. And when patients present with hypothyroidism, we really think of the symptoms here as being slowed down from normal. So when we have hypothyroidism, our heart rate can be lower, the metabolic rate can be lower, which means patients are burning less calories and weight may go up. They may have lower energy levels. They have drier skin and brittle hair. They may feel cold all the time or have intolerance to colder temperatures, as well as having slower bowel function, meaning they can have constipation. And how do we treat this? Well, it really comes to our T4 hero. What we really do in hypothyroidism is replace that missing hormone. We do this with a medication called levothyroxine. This is a really interesting medicine for a lot of reasons, I think. One being all the doses come in different colors, as you see here, which helps patients and doctors remember what dose the patient's taking. But it also has a lot of special instructions when taking this pill. For example, there's other medicines that you can't really take levothyroxine with. It can affect the absorption, and it has to really be taken on an empty stomach. So sometimes patients have to take it first thing in the morning before they've even had their morning coffee. So it's a great treatment, but it's a special medicine. Okay, now let's consider the flip side. What if we have high thyroid function or hyperthyroidism? How could this happen? We start with our regular loop again. Now let's consider that the command center is making too much TSH. It's telling the thyroid to just pump out thyroid hormone. So we have a really high T4 and TSH. Now here again, our feedback loop doesn't really work because our command center is not working. It can't listen to these feedback signals. This is what we would call a secondary hyperthyroidism. And in clinical practice, this is a pretty rare thing to see. Most of the time, if there's an injury to that pituitary command center, things are going to shut down rather than speed up. But if we did have this, we would see patients with a high TSH and a high T4. Now, another scenario to consider, we have to remember that hormones are messengers. They're messengers that bind to receptors. So we can see here we have our T4 or TSH binding to its receptor. But what if something else that looks like TSH could bind to that receptor? The thyroid doesn't know the difference. So the thyroid starts working and making a lot of T4, even though the pituitary didn't tell it to. In this case, our feedback loop is really going to be working hard. It's going to tell the pituitary that we don't need any more T4, and the pituitary is going to bring down that TSH. This is primary hyperthyroidism, where patients have a low TSH and a high T4. And why could this happen? Well, this is mostly due to something called Graves' disease, which is really the most common cause of hyperthyroidism. Similarly to Hashimoto's disease, this is also an autoimmune disorder. So there are antibodies involved in the disease process. In this case, you can see in this diagram, it's a little busy of a diagram, but what we want to look at is that there's a TSH molecule and there's an antibody just to the left of it that can both bind to this receptor in the exact same way. And the thyroid responds in the same way by making T3 and T4. Patients will have symptoms of hyperthyroidism. And here we want to think about things being faster or working in overdrive. So everything that the thyroid does, it's going even more. So our heart rate can be higher. Patients can have a higher metabolic rate, which can cause them to lose weight. Sometimes we'll say they have high energy levels, but it's not exactly what it sounds like. Patients may have high energy, but they kind of feel like they've done a really hard workout or they ran a marathon and they worked out all that energy and now they're feeling tired from that. They also may have sweaty skin compared to the dry skin in hypothyroidism and hyperactive bowel function, meaning diarrhea. And they may feel warm or have intolerance to really any heat. One of the interesting parts of Graves' disease is another aspect of it called thyroid eye disease. This really only happens in Graves', not other causes of hyperthyroidism. And you may know it because there are a lot of commercials about it on TV, like you can see here. But the reason this happens is that the antibodies that are triggering the thyroid to make the hormone can bind to a certain area near the back of the eye, in the area that we call the orbit. And you can see in this diagram at the top, the normal orbit is nice and clean and thin. On the bottom is the thyroid eye disease orbit. And you can see that the muscles and the yellow tissue behind the eye is all swollen and it looks bigger than the other normal eye. What this causes is patients to have pain in the eyes, redness, dryness. They can have changes in vision, as well as something called proptosis, which really means that the eyes bulge forward a little bit because of all this growth in the back of the eye. So how do we treat hyperthyroidism? Well, we have a few options. One of the areas we can target is the conversion of T3 to T4. And we do this with medicines called PTU or methimazole. These are pills that patients can take. The other option is really to just get rid of the thyroid. So this would be either through surgery, literally removing the thyroid, or through radioactive iodine, which takes advantage of that necessity of iodine in making thyroid hormone to really make the thyroid inactive. And thyroid eye disease is interesting because we can usually use the same treatments for hyperthyroidism, except radioactive iodine. This is actually shown in research to worsen thyroid eye disease. So we try to avoid that in patients who have this. But something that you may have seen on TV and commercials is this antibody that is specific to thyroid eye disease that will really only affect that part of Graves' disease. Okay, that was a lot of information, so let's just stop and check what we've learned. If you didn't have a chance to scan the QR code, you can scan it here, and we'll go over a question together. So we have a patient who is coming to the office reporting feeling her heart beating faster than usual. On her physical exam, she appears anxious, her skin is sweaty, the thyroid looks enlarged, and her eyes are mildly bulging. So we order blood work, trying to figure out what's going on with this patient, and what might we expect to see? Would it be a high TSH and a high T4, a low TSH and a high T4, low TSH and low T4, or high TSH and low T4? So we'll take a few seconds. Okay, maybe we can see how we're doing. Okay, so far we have most people voting on A. We have some for B, some for C, and some for D. Okay, let's go back to the question and talk about the answer. So our answer here is actually B. This patient is going to have a low TSH and a high T4. What we're really trying to get at in this patient presentation is that she has symptoms of hyperthyroidism, the high heart rate, sweaty skin, enlarged thyroid. And she has proptosis, or that bulging of the eyes, which we remember is specific to Graves' disease. Other causes of hyperthyroidism don't cause that. Since it's Graves' disease, we're going to remember that the T4 is high, but our TSH is low because our command center, our pituitary, is working and it's trying to keep everything in balance, but the thyroid itself is producing too much T4. Okay. So we are going to move on to our next endocrine organ, the parathyroid. And we had a little bit of a spoiler about the parathyroids. The main thing to know about their anatomy and where they are is that they're on the back of the thyroid, really tight on the back of it. There's about 4 of them usually. And what do? Well, they really are involved in calcium in our body. So we're going to start by talking about calcium homeostasis, or calcium balance, and how we achieve it in our bodies. And it starts with the parathyroids. They release a hormone called parathyroid hormone, or PTH. And PTH acts on a few systems, including the bones, the kidneys, and the gut. In the bones, it causes release of calcium from the bones into the blood. So the bones let go of calcium to increase our blood calcium. In the kidneys will reabsorb more calcium into the blood for the same reason. But the kidneys also have an enzyme that will activate vitamin D. And vitamin D then will work on the gut and cause the gut to absorb more calcium that we're taking in from our diet. And what do all of these things do together? They increase our calcium in our body. But just like any other endocrine system, there's always a feedback loop. So if our calcium gets too high, that's going to tell the parathyroids to shut down production of PTH to keep calcium levels normal. So what can go wrong with calcium? Well, let's talk about how we could cause calcium to be elevated. What if PTH was really high? One of the reasons that this could happen is something that we call a parathyroid adenoma. So you can see in this little picture, one of the parathyroids looks really big. So an adenoma is kind of like a tumor or a growth that's not necessarily cancerous, but it causes this hormone to be released all on its own, no matter the calcium. Another reason we might have high calcium is due to a hormone called parathyroid hormone related peptide. which is exactly what it sounds. It's a protein that acts just like PTH, but it's usually released from cancer cells. So these are two of the reasons that we might have high calcium. What happens whenever these hormones are high? Well, in the bones, it's going to cause even more calcium to be let go of the bones. The kidneys are going to reabsorb even more calcium, and the same thing is going to happen in the gut. This is going to increase our calcium even more, but it also causes other problems, including more breakdown in the bones and increased stress on the kidneys from all this reabsorption. And the feedback loop is going to try to turn this off, but there's reasons that sometimes it can't always turn it off. We'll get to it. When patients have high calcium, we think about the symptoms that they might have. And this is a pretty famous mnemonic that we learn in medical school. It's stones, bones, groans, thrones, and psychiatric overtones. So stones refers to kidney stones. Most kidney stones are made of calcium, so you can understand why if you have high calcium, you have more kidney stones. Bones refers to bone pain or bone breakage. As we saw before, bones are really involved with calcium. Groans refers to abdominal pain, which brings us to thrones, which refers to toilets, because patients can often have constipation from having high calcium. And finally, the psychiatric overtones really refers to mental status changes that patients can have that can be as simple as some mild confusion, but can be more severe disorientation at the worst ends. And when we think about why do we use this clinically, we have to think about the different disorders that the parathyroids are involved in. And we use these labs to try to determine what the problem is. So if we see a patient that has a high calcium and they have a high PTH, why might this happen? Well, the most common reason would be that the parathyroids are working overtime. Even though the calcium's high, they're releasing PTH. And this would be like what we talked about before with the parathyroid adenoma being the most common cause. What if, for example, the calcium was high, but the PTH was low? Well, there's two main reasons. And one could be eating too much calcium. One of the most common things we learn in medical school is a condition where sometimes patients eat too many Tums. And you can see here, Tums are made of calcium carbonate. So that could cause you to have a high calcium level. Another reason would be if patients are having high levels of PTH-RP. So if you check the labs, the PTH looks like it's low, but if you checked PTH-RP, that would probably be high, and that would be the reason. If we think about a low calcium level, if a patient has a low PTH as well, we have to wonder, are the parathyroids working, and are they even there? For example, if a patient had their thyroid removed for hyperthyroidism, it's not uncommon that a parathyroid could be removed with it and cause that condition to happen. Another part of the parathyroids that is interesting is that their effect on bones. So as we talked about, having a high PTH causes more bone breakdown in that attempt to raise our blood calcium levels. In really severe cases, we can have a condition called osteitis fibrosa cystica, where patients have severe bone pain, they can have abnormal fractures and deformities of the bones, as well as a low bone mineral density. Fortunately, this can be reversed with the treatment of the hyperparathyroidism. So we'll look at some pictures of that. You can see here on the left picture, these are x-rays of bones. Where those arrows are pointing are places where the bone has been broken down due to this really high PTH. On the right picture, the top panel shows that bone breakdown. And then on the bottom, you can see that some of the bones look healthier. They look like they've gotten stronger and they don't have as much breakdown. And in those pictures, the patient had been treated for their hyperparathyroidism, which just shows you that the bone disease can be helped by treating the overall condition. All right, so let's just take a little break and check what we've learned again. You can scan this if you hadn't before. So this question, we have a patient coming to the office for a follow-up after recently going to the emergency room after having their first kidney stone. They also tell us that they've had increased constipation, abdominal pain, some pain in the extremities, and mild confusion. On their labs, both their calcium and their PTH are elevated. What is the most likely source of their high calcium? Would it be a parathyroid adenoma, lung cancer releasing PTHRP, or were they maybe eating too many Tums? Take a second and think about it. All right, let's see what we've got. Okay, we have a strong crowd choosing parathyroid adenoma. Some for the other choices too. Let's see what the answer is. So our answer here is parathyroid adenoma. So like we talked about, this patient has the symptoms of hypercalcemia: stones, bones, groans, thrones, all of them. Since their PTH is high and their calcium is high, their feedback loop is not working. So the source has to be some abnormal release of PTH from the parathyroid. If it was due to eating too many Tums, the PTH would be low because the feedback loop still works, and the high calcium tells the parathyroid to not produce PTH. Same thing would happen if it was due to PTHRP. So great job, guys. Okay, I'm going to turn it back over to Dr. Donnelly, and we'll keep talking about endocrine organs.
All right. Thank you, Elizabeth. It's interesting to see the way all these feedback loops are working and what happens when they aren't working. So let's move on and talk about the adrenal gland. And the adrenal gland is really special because it makes multiple hormones. The adrenal glands are located just above the kidneys, and there's two adrenal glands, one above each kidney, and so it's adrenal. So kidney is renal, so this is above the kidney. So that's how it got its name of the adrenal gland. Each adrenal gland makes multiple hormones and has different ways of feedback loops. And we're going to show one that's a really kind of a different feedback system. First thing to think about with the adrenal is most of the hormones made by the adrenal gland are steroids. And I think that when we think about steroids, we think of this, right? We think of like, going to the gym and getting stronger when we think of steroids. But there's really a lot of different kinds of steroids. Steroids are actually typically hormones that are fatty hormones. They actually are using a cholesterol structure to create these hormones. And so different hormones that we see that are steroid hormones include aldosterone, which is known as a mineralocorticoid. Mineralo means it alters the minerals of your body, like the sodium and the potassium, and we'll talk about that. Cortisol is another steroid that many people, I think, have heard about. If you get a cortisone shot, that's a very similar type of thing, and we'll talk about that. And then DHEA is dihydroepiandrosterone. This is actually a precursor of testosterone that your adrenal gland makes. And the adrenal gland is interesting because it has a couple of different areas. The outside of the adrenal gland is known as the adrenal cortex, and the inside of the adrenal gland is known as the adrenal medulla. On the adrenal cortex, it's broken into 3 different zones. Each zone makes a different hormone. So we learn about it in med school of GFR, so glomerulosa, fasciculata, and reticularis. So zona glomerulosa makes aldosterone. That's our mineralocorticoid. It changes some of the sodium and potassium balance, and it affects blood pressure, which we'll talk about. The zona fasciculata is that central part of the adrenal cortex, and it's the largest part of the adrenal cortex, and that makes cortisol. And cortisol has many, many different functions, which we'll talk about. The zona reticularis makes the dihydroepiandrosterone, which is DHEA. Like I mentioned, that is a testosterone precursor, which our bodies generally get most of our testosterone, particularly men, from the testicles. And so those sex glands, testicles or the ovaries, are the ones most likely to be responsible for estrogen and testosterone production. But there is some effect from the dihydroepiandrosterone, particularly around puberty initiation and development of sexual traits during during fetal development, which we won't really get into that much. But it is important because when that adrenal cortex is stimulated, you may get some effects from the dihydroepiandrosterone. And then the adrenal medulla, we're not really going to talk about that much because it is a very different system. The adrenal medulla is actually stimulated by the nervous system, particularly the sympathetic nervous system, and it creates two hormones known as epinephrine and norepinephrine, which you probably know of epinephrine by its other name of adrenaline. So when you get stimulated, scared, nervous, the sympathetic nervous system tells the adrenal medulla to pump out those hormones. And so that is a different talk on the nervous system, which we really won't talk about. Again, coming back to the pituitary has a big effect on the adrenal gland through the function of the hormone adrenocorticotropic hormone, or ACTH. So let's talk about our first hormone, aldosterone, which I mentioned is a mineralocorticoid. It is part of a bigger system of hormones known as the renin-angiotensin-aldosterone system. Its primary function is to manage blood pressure and keep the sodium and the potassium in balance, and it works on the kidneys. So we'll kind of walk our way through the renin-angiotensin-aldosterone system, and we'll show the way that there's clinical applications in altering the renin-angiotensin-aldosterone system. So this is really about blood pressure control, and the story starts in the kidney. The kidney is very sensitive to changes in blood pressure. And so when there's a change in blood pressure where it may be dropping a little bit, or maybe the sodium levels are dropping a little bit, or that sympathetic nervous system that we were talking about innervates, the nerves are going in there and giving signal like we need to raise the blood pressure, then the kidney will respond. The response of the kidney is through an enzyme called renin. So renin is released from the kidney. Renin will then interact with a protein that's made in the liver. So this is a hormone type protein made in the liver called angiotensinogen. When renin interacts with angiotensinogen, it makes a hormone called angiotensin 1. The problem with angiotensin 1 is it's not a very effective hormone. It doesn't really do a whole lot. And so what we need to do is we need to take angiotensin 1 and we need to make it more powerful. And we do that through an enzyme called the angiotensin converting enzyme, which is found primarily in the blood vessels of the lungs, but really throughout the body. And what angiotensin converting enzyme does is it takes angiotensin 1, it cuts it a little bit to turn it into angiotensin 2. And angiotensin 2 is very powerful. It's a powerful hormone that has a number of different functions. The first thing it does is it goes to the kidney, it alters the blood flow through the kidney to try to improve some of the function of the kidney so that the kidney is filtering more effectively and ultimately changes the blood flow and signals blood pressure increase. It goes to the pituitary gland, and in the pituitary, it signals the release of antidiuretic hormone, ADH. ADH goes to the kidney and says, hold on to more water. So now we're holding on to water, and then it signals the adrenal gland to release aldosterone, which says hold on to sodium. So the combination of holding on to water and holding on to sodium effectively increases blood volume and increases blood pressure. So through that combination effect, we're getting an increase in blood pressure. And then lastly, angiotensin 2 is a potent vasoconstrictor. So if you take a blood vessel and you shrink the blood vessel, you increase blood pressure through actually restricting the actual space where that blood is going. So you will have an increase in blood pressure. So all of these things effectively raise the blood pressure. Once the blood pressure raises, renin production decreases. So all that angiotensin is no longer being converted into angiotensin 1. So you can see then that feedback loop is complicated because there's multiple steps, but there's still a feedback loop here. So how do we use this then? Because I think we know that high blood pressure is a problem. So blood pressure medications can take advantage of this system to try to reduce blood pressure. So it's very unfortunate that blood pressure for many patients is high, and the system that is designed to kind of get our blood pressure to where it should be is overacting. And through many other factors, patients who have high blood pressure have a dysfunction of their blood pressure. And this is one of the reasons that that can happen. So what can we do? Well, why don't we go ahead, we'll block the angiotensin converting enzyme. So we take a medication that prevents the angiotensin converting enzyme from working. It effectively reduces angiotensin 2. So therefore, you're not getting the effect on the kidney circulation. You're not getting the stimulation of the pituitary. You're not getting the stimulation of the aldosterone. And you're not getting that vasoconstriction, which ultimately will lower the blood pressure. So that is one of the things that we can do, which is an angiotensin converting enzyme inhibitor. These are common blood pressure medications that many people have heard of, known as ACE inhibitors: lisinopril, enalapril, captopril, benazepril. So those are very commonly used in medicine as a blood pressure medication. What else can we do? Well, there are other ways to do it. Why don't we go ahead, rather than blocking the conversion of angiotensin 2, let's just block the angiotensin 2. Let's block it where it works. And that means its effect on the kidney, its effect on the pituitary, its effect on the adrenal gland, and its effect on those blood vessels. So if we block it there, we're using a medication that is called an angiotensin receptor blocker, known as an ARB. So we have ACE inhibitors, angiotensin converting enzyme inhibitors, and ARBs, angiotensin receptor blockers. Also common medications you may have heard of, particularly losartan, valsartan. These are very common for your patients with high blood pressure. All right. And then lastly, if we look at the system, let's go back to our original hero, aldosterone. And it is one of the other targets that we can use here, which is we can just go ahead and block the aldosterone. So that maybe it's not quite as effective, because you can see if we're blocking angiotensin, it has multiple areas, but it is still another area that we could affect. And so that is a blood pressure medication that not only lowers blood pressure, but because of strong effect on aldosterone, you may see some changes in sodium. Sodium may go lower, and particularly potassium can go higher, which we do look out for. This is a class of medications known as a mineralocorticoid receptor antagonist. So it's an aldosterone blocker. We can abbreviate that to an MRA. Commonly used mineralocorticoid receptor antagonists include spironolactone and eplerenone. So those are common medications. Now, if we look at the adrenal gland, and in this system, just like we saw in some of those other feedback loops, what happens if the adrenal gland is really overacting? One of the places that can happen is through the effect from the pituitary. So the ACTH, its primary function is to tell the adrenal gland to make cortisol, but it can make some extra aldosterone. But sometimes the problem is in the adrenal gland itself. There could be hyperplasia or excess growth of that area of the adrenal gland, and it can start making too much aldosterone. When it does that, we call this Conn's syndrome. And what we know is that it can cause blood pressure to be lower. It can cause sodium to be lower. Blood pressure to be higher, sodium rises, and the potassium lowers, because aldosterone holds on to sodium and secretes potassium from the kidney. So when you have high aldosterone, you have sodium retention and potassium loss, and then the blood pressure will rise. So Conn's syndrome is one of the things that we think about in a patient that has high blood pressure. How are we going to treat that? Well, it's pretty obvious that the way that we're going to treat it is by blocking the aldosterone with one of those medications like spironolactone. All right. So Elizabeth, I'm going to hand over to you for question number 3.
All right. So the RAS, or renin-angiotensin-aldosterone system, is an essential mechanism for blood pressure control that uses hormones to send signals that can raise blood pressure. For many patients, high blood pressure is causing more harm than good. So when we consider the RAS, what would be a good target for a medication to lower that blood pressure? Could it be A, block the effect of aldosterone, B, block the conversion of angiotensin 1 to angiotensin 2, C, block the receptor for angiotensin 2, D, block the effect of renin, or E, all of the above? Take a second and think about it. Okay, let's see what we've got so far. So most people are choosing all of the above, a few for the other options. Okay, let's see what we have for the answer. So it is E, all of the above. So as Dr. Donnelly said, common blood pressure medicines are those ACE inhibitors, ARBs, mineralocorticoid receptor antagonists. And although not commonly used, there are medications that block renin called direct renin inhibitors that can also reduce blood pressure by decreasing that production of angiotensin 1. So it's all of the above.
All right, good test-taking strategy. We asked you a question we didn't fully teach you, so well done to all those who got that one. All right, so let's move on to our next hormone, cortisol. Cortisol, again, remember our picture of the adrenal gland is made by the adrenal cortex, the adrenal fasciculata. And so what it does is we consider it a stress hormone. So a stress hormone, it interacts with the control of fats and proteins. It is involved with your sleep-wake cycle, your blood sugar production. So we'll talk about that. So think about cortisol as getting you ready for action. Cortisol levels are highest in the morning. They drop when you're sleeping, when you don't need energy. And then as you need energy, they will climb during the morning to kind of get you ready for your day. So what do they do to get you ready for action? And I want you to think about this when we talk about all the actions of cortisol on what could happen if you have too much cortisol, because spoiler alert, we're going to get to that. So the first thing cortisol does is it will give notification to your liver to try to increase glucose levels through the process known as gluconeogenesis. And so the idea is let's get some sugar and let's get it ready to go. It can also tell your fat to start utilizing fat. So it goes to your fat cells and says, let's use those fat cells. What's interesting though, and we're going to talk about this a little bit more, is it doesn't interfere with fat in all the areas of your body equally. It seems to more preferentially remove fat from people's arms and legs, but then deposits fat into the central area, particularly if there's too much cortisol. So we talked about glucose, so sugar, carbohydrate, fat, these are energy sources. Well, what's our next energy source? Protein. So what cortisol is going to do is try to find areas of protein. What's our biggest source of protein in our body? Muscle. So what this is actually doing, even though we think, oh, we want our muscles to be really strong for action, first thing you want is energy though. So if you have energy, you can then do what you need to do. So cortisol will actually look for protein. It can actually cause some muscle breakdown in minor ways through your day. That's not something you're ever going to notice because you get a little bit of protein, and then that protein's probably redeposited into the liver. You can also go to the skin and actually start using some of the protein in the skin known as collagen. And so then you can get skin breakdown. Again, in your normal day, this isn't going to cause a problem. And then the other place it can try to find protein is in the bone. So Elizabeth talked about pulling calcium out of the bone from parathyroid hormone, but cortisol actually works on the protein structures of the bone. And so it can cause thinning of the bone. In the blood vessels, it actually causes an interesting reaction to white blood cells. So it sort of, think of it as sort of stiffening up white blood cells. So rather than them getting out of the blood vessels and going to areas of infection, they kind of stay in the blood vessel. Think of it, they're sort of ready for action in the blood vessels, but they're not actually being used yet. So we do see sometimes white blood cell levels can go up with cortisol levels. In the circulatory system, it does have some effect on some of those mineralocorticoid receptors. So maybe it has some effect on blood pressure, but really it actually improves, it enhances the sympathetic nervous system, which will cause vasoconstriction. Remember, we said vasoconstriction raises blood pressure. So get that blood pressure up and ready for action. And then lastly, it has an effect on the nervous system to stimulate. And so if you have stimulation with energy, blood pressure's up, that means that you should be ready to go. So let's talk about the feedback loop of cortisol. So this is very similar to our thyroid feedback loop. The story starts in the pituitary with the hormone ACTH, adrenocorticotropic hormone. ACTH then signals the adrenal gland to make cortisol. Cortisol does all these things that we had talked about. And then it feeds back to the pituitary gland and says, we don't need more ACTH. We have enough cortisol. We don't need ACTH. So feedback loop works when ACTH sends the signal, the cortisol goes up. That cortisol then reduces the amount of ACTH and keeps it in balance. Well, let's talk about too much. So if we have too much cortisol, it's typically known as Cushing syndrome. So this is named after a physician from 100, 200 years ago when he had discovered that high levels of cortisol led to illness. So what can cause too much cortisol? Again, this is going to look similar to the thyroid. What if we have an adenoma? So it's a hormone secreting tumor, non-cancerous in the pituitary gland, and it makes too much ACTH. It's telling the adrenal gland, you need to pump out more cortisol. That ACTH also has some effect on the aldosterone and the DHEA. So all of them are going to rise, the cortisol more than the others, but they're all going to be stimulated by that ACTH. As a result, these are the symptoms: high blood pressure, increased glucose, increased fat deposits. So we talked, the fat can pull out of the extremities, but then it gets deposited in the abdomen. Because what's interesting is you're not actually, you don't actually need that fat. So it breaks down and then it deposits where you don't need it. One of the common areas for Cushing syndrome is fat accumulation in the face and fat accumulation between the shoulder blades that's known as a buffalo hump. You can get decreased muscle mass. Remember, cortisol goes to the muscle. It tries to pull protein out of the muscle. So you get decreased muscle mass, decreased bone mass. It's pulling the protein out of the bone as well. You can have poor wound healing and stretch marks. Remember, there's an effect. It can pull protein out of the skin. And then easy bruising and acne. And acne is probably somewhat related to DHEA, which is a testosterone type of hormone. So if the problem is coming from the pituitary, what happens with the feedback loop? It doesn't work. The command center is not going to listen to that cortisol anymore. So you have high ACTH and high cortisol. And that is what we would see in a pituitary tumor, pituitary adenoma. All right, similar to the thyroid, what if the problem was in the gland itself? So the gland is making too much hormone. The cortisol is going up because of that. You have the same types of symptoms that you would. Maybe that gland is producing, or maybe that gland is producing too much of those other hormones as well. So similar symptoms. The feedback loop is then telling the pituitary gland, no more ACTH. We don't need it anymore, but the adrenal gland's not listening. It's going to keep pumping it out. So in this situation, low ACTH, high cortisol means that the problem is coming from the gland. All right. All right. And one of the most common causes of too much cortisol is actually people taking cortisone type medications. When you take cortisone, so think about that as hydrocortisone, prednisone, prednisolone, solumedrol, dexamethasone, those medications which have incredible uses for treatment of as anti-inflammatories for say asthma, autoimmune problems like lupus, all of those things may require people to take cortisone or cortisone type medications. They have a great effect, but they have potential side effects. So if somebody's taking a lot of those medications, it acts like cortisol. So what's the first thing it does? It tells the pituitary, there's plenty of cortisol around here. You don't need to make ACTH anymore. So the pituitary slows down the ACTH production, and then the adrenal gland slows down the natural cortisol production because that cortisone is doing all the work. And that feedback loop doesn't work anymore. The pituitary thinks it doesn't need it. It doesn't need to make ACTH. Same symptoms. So too much cortisone medication can give you the same exact symptoms. So taking too much medicine, we call that exogenous. So if it comes from inside your body, it's endogenous. If it comes from outside your body, it's exogenous. So low ACTH, and then your cortisol level, if you check a blood test, it depends on which type of medication you're taking. Some of it shows up as cortisol, some of it doesn't. So that gets complicated, but the most important thing is knowing that your patient's taking that medication. So what does Cushing's syndrome look like? We talked about the symptoms, and this graphic kind of helps highlight some of it. Here's this buffalo hump. People can get red face or a lot of fat deposits in their face. If you look, she has a lot of truncal obesity, so fat deposits in the abdomen, but thin muscles and thin arms and legs. Easy bruisability, and then stretch marks, which we call striae. So that skin breakdown with the weight gain is known as striae. So how do we go ahead and treat Cushing's syndrome? Well, it depends on where the problem is coming from. The most common cause is actually a pituitary adenoma that can be treated by surgery or radiation. There are some medications that can reduce the ACTH production, like cabergoline, or can reduce the cortisol production, like ketoconazole, or can reduce the cortisol effect, like mifepristone. But what's most effective for treating a pituitary adenoma is actually surgery. And the way to do the surgery is what's known as a transsphenoidal approach. This looks terrible, but is probably much, much better than brain surgery where they have to go through your brain. So what this effectively does is there's a surgical instrument that goes through the nose and makes a hole in the base of the skull up here and is able to get access to the pituitary gland that way. And so it is a fairly minimally invasive surgery that does not need to cut brain tissue. So this is an incredible development in a way to treat treat pituitary tumors. If the problem's in the adrenal gland, then adrenal surgery may be necessary. And if the problem is taking too much medication, then reducing the amount of medication. All right. All right, so let's talk about adrenal insufficiency. So we talked about too much cortisone. Well, let's talk about low cortisol and aldosterone. So the adrenal, if you're not getting those hormones out of the adrenal gland. So adrenal insufficiency, the most common cause of adrenal insufficiency is taking exogenous cortisone. And you might pause for a second and say, wait a second, Dr. Donnelly just said that's the most common cause of Cushing's disease, but let's talk about it. Let's say you take too much cortisone. What's going to happen? We already said this. Pituitary, it shuts down ACTH production because it thinks there's enough cortisol around. The cortisol level is going to drop off because the adrenal gland doesn't need to make it anymore because you're already taking it. The feedback loop kind of shuts off. And the adrenal gland actually shrinks because it doesn't need to do it. Now, what if we get rid of the cortisone like that? It's gone. So if you do that, you go from taking cortisone to not. What's going to happen? Pituitary, it's going to take a while to wake up. The adrenal is going to take a while to wake up. It's already shrunken down. And so then people are left without any effective cortisol. Symptoms: fatigue, weakness, weight loss, low temperature, low blood pressure, low sugar. So opposite problems of too much cortisol. So pituitary suppression and adrenal suppression would be found with low ACTH and low cortisol levels. And this is most common from taking exogenous steroids. All right. What if the problem's in the pituitary? Similar, ACTH decreases. The adrenal gland doesn't get the signal. Cortisol decreases, feedback loop doesn't work because the pituitary command center is not working. Same symptoms, adrenal insufficiency. If you're not getting the signal to the adrenal gland, it's not telling your body to make cortisol. All right. So pituitary failure will have low ACTH and low cortisol. And guess what's coming next? All right, adrenal gland failure. Now, adrenal gland failure is very interesting. If the adrenal gland just stops making the cortisol, it's probably also going to stop making aldosterone and DHEA. And so you just don't have these hormones around anymore. Same symptoms, but now that the adrenal gland is kind of shut down, the aldosterone, so even though that signal through the RAS is coming in there, it can't make the aldosterone. You're going to start getting low sodium, high potassium because of low aldosterone levels. Low energy levels are exacerbated by low DHEA. And then look at the last symptom here, tan skin and mucous membranes. What does that mean? And that seems weird. What happens is, what's this feedback loop going to do? The pituitary is working and there's low cortisol level. Low cortisol is signaling the pituitary, make more ACTH. ACTH levels are going to go up, but the precursor for ACTH also is another hormone called melanocyte stimulating hormone. So the precursor for ACTH goes to both. Melanocyte stimulating hormone goes to the skin to interact with melanocytes, and melanocyte is what gives you pigment in your skin. The more stimulated those melanocytes and the more melanocytes you have, the darker your skin. So what could happen is if a person has adrenal failure, ACTH is high, melanocyte stimulating hormones high, the patient can actually get darkening of their skin. So this is known as Addison's disease, and it's an adrenal gland failure. The symptoms, as we had mentioned there, you can see an example of the darkening of the skin. It is exacerbated in sun-exposed areas and joints, so maybe on the back of the hand, over the knuckles, you might see it. But interestingly, you get pigment deposition within the creases of the hand, which is pretty unusual otherwise. This cave is actually somebody's mouth. I just did a close-up here, but you can see all that darkening in the inside of somebody's mouth is not normal, and that could be a sign of increased melanocyte stimulating hormone in the setting of Addison's disease. Interestingly, from a pop culture reference, President John F. Kennedy was known as having Addison's disease since he was a child and had been treated with it through his presidency. So Addison's disease can be treatable, but what's an Addisonian crisis? Addisonian crisis or an adrenal crisis is life-threatening, a life-threatening low blood sugar, low blood pressure, and high potassium. So there's not enough cortisol or aldosterone around because that adrenal gland is suppressed or is not working. That is typically triggered by stress, or stress hormone is no longer available. So stresses such as surgery, infection, and when people are unable to take their medication for Addison's disease and then exacerbated by these things. So shock, so low blood pressure to the point of shock, and then high potassium can cause alterations in the conduction of electricity across the heart muscle and can lead to dangerous heart rhythms that can be deadly. So how do we treat adrenal failure? You replace the cortisone. So that is the primary way to do it. Hydrocortisone replacement. Typically a daily dose of hydrocortisone is 5 to 10 milligrams 3 times per day. But when people have stressors, you need to bump up the dose. And so patients are instructed how to take their medication if they get an illness. If they have a cold virus, a fever, maybe a minor surgery or procedure, they should double up on their dose of daily cortisone. If it's a moderate stressor, like they're going for a surgery, like a general anesthesia, maybe a 3 times dose. And a major stressor, like they're in an ICU, they're just going to get blasted 100 to 200 milligrams of cortisone. For fludrocortisone, that is the replacement for aldosterone. So if somebody's having low blood pressures despite getting hydrocortisone back, they may need fludrocortisone. And you can supplement DHEA, and that can help energy level, sexual function in patients as well. All right, we are coming to the end. So this is our last quiz question. Elizabeth, I'm going to go ahead and turn over to you.
All right, we've learned so much. So in this case, our last question, we have a patient coming to the ER with severely low blood pressure. The family reports that the patient had the flu for the past 3 days and weren't able to take their normal medicines. On their vital signs, their heart rate is 100, a little bit high. Their temperature is 96.5. Respirations are 22 per minute, and their blood pressure is 72/35, which is low. On their physical exam, the patient is nearly unconscious with cold, clammy skin. The skin appears darkened on their hands, and there are some darkened areas on their lips. Their labs show low blood sugar, low sodium, and high potassium levels. In addition to giving them IV fluids for volume replacement, what is the most important next step of their treatment? Our choices are starting IV antibiotics, giving levothyroxine 100, giving 20 of hydrocortisone, giving 200 of hydrocortisone, or giving 50 of spironolactone. All right, let's see what answers we have so far. So we have about 50% at 200 of hydrocortisone, about 25% choosing 20, a few for the other options. So let's see what the answer is. So our answer here was 200 milligrams of hydrocortisone. So as you probably deduced from this case, this patient has shock, and it seems like they have an adrenal crisis and they need immediate stress dose hydrocortisone. They were ill at home and probably unable to take their hydrocortisone, and that's why they're having this presentation. The trick in this question is that we had two options for hydrocortisone, 20 or 200, but when patients are this sick, coming in very severely ill, we have to make sure we give them the high dose cortisone. Otherwise, they can have worsening shock or serious irregular heart rhythms and possibly even death. Another interesting part about Addison's and the adrenal crisis is that it's recommended for patients to have some kind of medical ID on them, like this bracelet you see here. So if these patients come to the emergency room, like the patient in this case, they know then that this patient may need stress dose hydrocortisone very quickly.
All right. Thank you, Elizabeth. So we covered a lot of information, and I think that, we wanted, there's so much to talk about the endocrine system, but we wanted to really start with some of the basics to be able to show that physiology and pathology are closely related. And things that we do in medicine are about really trying to create balance back to these things. The pituitary gland, feedback systems, they all kind of matter with the endocrine system. And remember, if a gland is overstimulated or forming a tumor that's secreting hormone, we get too much hormone. If a gland is understimulated, you get too little hormone. And it depends on where the problem is in that feedback loop. Medicines can help restore function by replacing or suppressing the endocrine system. So it depends. Is it too high? Then we need to slow it down and rebalance it that way. If it's too low, we need to get hormone back into that patient. So are they villains or are they heroes? I think that we believe that the hormones are truly the heroes of the story. They do incredible work for us in our bodies to give us energy, to keep things in balance. Little known things like managing our calcium, our sodium, our potassium, our blood pressure all interact with hormones in our bodies. And so we really hope that we've left you with an idea that, first of all, physiology is really cool, medicine is really cool, and this is a great way to sort of understand the way we learn medicine in medical school, and the way that you can try to advance your learning as well. There's some great online resources to further your learning. There's some really, really good YouTubers out there that that's all free, that you can learn about some of these things. It's a YouTube channel called Osmosis. There's one, certainly the Khan Academy, which I think a lot of people know about from their schooling. And there's another one called Ninja Nerd, and they use a lot of graphics and ways to present the information. There's also really free resources that's sponsored through the National Institute of Health called Stat Pearls that has incredible data out there if you want to learn things. So thank you, everybody. Elizabeth, let me actually give a shout out to Elizabeth. As a medical student and now physician, she has done an incredible job to prepare and present this information. I'm really thankful to have her as a partner in this presentation today.
All right, are we ready for some questions from the audience?
I think so. I need to take a drink though. That was a lot.
All right, thank you. That was quite a lengthy presentation, but we had quite a few people in the chat saying what great information you shared and what little they knew about endocrinology to begin with. So we're going to go through as many questions as possible, but we do have quite a few and only, I think, 40 minutes. So we had a question in the chat. Can your thyroid switch back and forth between hyper and hypo?
I'll go ahead and take a stab at a lot of these. What's interesting is it can sometimes start hyper and then move to hypo. So once you get to hypo, though, it's not usually going back. So there are some inflammatory conditions of the thyroid, thyroiditis. One of the ones that Elizabeth taught us about was Hashimoto's thyroiditis. And when it starts, sometimes it can actually stimulate the thyroid gland a little bit until that scarring and inflammation sort of takes over and the thyroid kind of burns out after that. So the answer is you can go from hyper to hypo, but not typically from hypo to hyper.
Okay. All right. And we had a question. Why is ADH not talked about with patients who have CKD? Does it have bearing?
Yeah, ADH is, so if you notice when we were talking about blood pressure medications as well, we did not talk about blocking ADH. ADH is so essential in balancing the sodium and water balance that really it's not something that you can interfere with. We do have patients admitted to the hospital sometimes with too high or too low sodium. And it sounds like that's a sodium problem, but a lot of times it means that the water is out of balance. And so really is something that we don't want to mess around with ADH in our patients. The ADH is not a cause of CKD or a result of CKD, but it's necessary to trigger the kidney to hold on to water.
Okay. All right. We had another question here. I know you said we don't talk about reproductive hormones. However, are there any interactions between reproductive hormones and cortisol, i.e., can those two systems interact?
They do interact. What's different is the DHEA is one of the testosterone precursors. The reason that that's most important in fetal development, particularly for men, is that once the testicles are formed, then the testicles produce so much more testosterone that the DHEA almost becomes irrelevant. But for women, that DHEA still matters a little bit because they don't make as much testosterone otherwise. So it does matter. But what it does matter as well is, remember we talked about when the pituitary gland is stimulated and all that ACTH is pumping out, you can get that melanocyte stimulating hormone. Well, sometimes when that pituitary is really getting stimulated that way, you can also get some of the other hormones that trigger the sex hormones. So it's the FSH and the LH will sometimes then kind of ramp up. And so a low cortisol level triggering the pituitary to be overactive can sometimes interact with those other hormones.
Okay, great. You're doing so well for being on the spot like this. All right. Do people that avoid iodized salt have other problems because of low iodine?
The primary issue with low iodine is about thyroid hormone production. Most of the salts that you're going to get in the United States is going to be iodized. In fact, most of the world is now has iodized salt. So even if you're eating French fries from McDonald's, that salt is iodized. So it's almost impossible to avoid iodized salt. But that is really the primary issue for the iodine.
Okay. Should someone who is hypothyroid but also has HTN use added salt due to the need for iodine?
Yeah, again, there is enough salt in what you're eating that's iodized that you do not need to add extra salt.
Okay, great. You mentioned iodine in the thyroid. Can you explain the connection of this hypotonic to hypotonic or hypertonic solutions? Would this not dehydrate or overfill the cells with water in response to the salt?
Yeah, there's certainly there needs to be a balance there. And so what we're talking about then is hypertonic or hypotonic. If your cell has too much salt in it, then it pulls too much fluid into it, and that's bad for the cell. But this is very well balanced. So whether it's iodine, sodium, potassium, all those things are extremely well balanced.
Okay. Is someone with one autoimmune disorder more likely to have others, such as arthritis?
Yeah, absolutely. The autoimmune diseases do often run together, and we talked about some of these autoimmune diseases in the thyroid. You know, some of the problems with the adrenal gland can be autoimmune, and absolutely. So it is not unusual for people to have different problems, and diabetes can actually be similar with this, where the pancreas just isn't as effective because of autoimmune problems.
Great. All right, this one, what is the role of antibodies on a normal basis in comparison to their role in hypothyroidism?
Yeah, I mean, antibodies are essential for our immune system. And so when you have the antigens and antibodies, so those proteins, and then your body's immune system, the goal of those antibodies is primarily to fight off things that come from the outside of your body, like an infection, but they can also bind to your own local tissues that could have some benefit unless they are overactive or binding into the wrong place. And so antibodies have incredibly important things that they do for us, but that is the immune system antibody production is what leads to autoimmune disorders.
Okay. All right, we had a question from Angela. Can you briefly address thyroid nodules?
Yeah, thyroid nodules often are not active. And so if we feel a knot in the thyroid and we do an ultrasound of that thyroid and we see that there's a nodule in the thyroid, most often that nodule is not producing any hormone. As far as the way to address thyroid nodules, there are some complicated ways to look at it. It somewhat depends on the size of the nodule, the appearance of the nodule on the ultrasound, so the radiologist can give us guidance on what the next steps are based on those things. And then based on that information, makes a decision, does that nodule need a biopsy? And then if it needs a biopsy, then that will determine what causes it and then what the next steps are. Most thyroid nodules are not cancer, but certainly that's what you worry about, is that somebody could develop a thyroid cancer. But luckily, most of the time we see nodules, they're just kind of lumps on the thyroid that aren't doing anything.
Okay, great, thank you. Does the parathyroid cause the calcium flow to bind arbitrarily, like a calcium deposit in an odd location?
Yeah. Calcium goes to where it should go primarily, but as Elizabeth said, you can get kidney stones, and there are times that you can get too much calcium deposits in the skin. But calcium, one thing we didn't talk about is phosphorus. So calcium and phosphorus kind of work together. And the most common time you're going to get deposits of calcium is if both the calcium and the phosphorus are high, which doesn't typically happen in hyperparathyroidism. So the answer is yes, that can happen, but it can get more complicated depending on what the phosphorus levels are.
Okay, and this kind of plays into Amy's next question. How does parathyroid play into osteoporosis?
Yeah, great question. So Elizabeth and I had talked about presenting that. There are ways to alter the parathyroid effect on bone to try to improve osteoporosis. But it's typically 99% of patients with osteoporosis do not have hyperparathyroidism. They have an age-related bone breakdown, and that bone breakdown can be from low calcium, but can also be from low protein, just like we were talking about with the cortisol reducing the protein in the bone, that will also lead to bone thinning. So when you have a combination of lower protein and lower calcium in the bone, that typically leads to osteoporosis. So the answer is it is related. There is an effect there that can be altered with medication, but it's not the typical cause of osteoporosis. And as Elizabeth had presented, patients with hyperparathyroidism can sometimes get really severe bony breakdowns, but it's different than osteoporosis.
Okay. Great. We had a question from Beth. With hypothyroid, what should be tested annually besides T4?
So with hyperthyroidism, so typically, you said hypothyroid, right?
Yeah, right.
So typically you actually look at the TSH level. If you take your thyroid hormone, then the TSH should be normal. But if you're not getting enough thyroid hormone, then the TSH level is going to go up. And so that's actually more important to look at, is the TSH level.
Okay.
Now, we usually do it in conjunction. So you check the TSH level. If that's normal, the T4 should be normal, but a lot of times we're kind of checking both to see what that ratio is between the two to make sure that it's still in balance. But the TSH should be normal if you are taking enough thyroid hormone.
Okay. Great. How can thyroid goiters affect you? I hope I'm pronouncing that right.
We didn't address goiters specifically. You can have a goiter on either side of that. Hypothyroidism or hyperthyroidism can cause a goiter. So anything that is sort of stimulating the thyroid may cause a goiter. So remember, Hashimoto's thyroiditis, even though the thyroid is no longer working, the thyroid is inflamed and kind of scarred and everything, so you can get a goiter. For those out there who don't know, a goiter is an enlarged thyroid, and you may see it, somebody who has like this kind of lumpiness to their neck in the front, and that's because they have a visible thyroid gland there. Hyperthyroidism, like Graves' disease, can also cause a goiter, where your thyroid gland is so stimulated that it's growing larger. And then some people can also get goiters from multinodules. So we talked about thyroid nodules, but a bunch of tiny little knots on the thyroid will actually cause the thyroid to get enlarged as well. Iodine, which we talked about, one of the most common causes of goiter in developing world with poor, in areas with poor nutrition or food scarcity, is actually low iodine levels, high TSH level because the T4 goes down, and then the thyroid grows and you get a goiter.
Okay. Are lytic lesions tied to parathyroid bone disease?
Yeah, not directly. Now, when you have, so lytic lesions, meaning a area of the bone that is broken down. Elizabeth had shown some images where the lytic lesions were related, but most commonly, say you have a cancer that goes to the bone, and then you get a lytic lesion from that. Typically what happens is the calcium levels go up from the lytic lesion, and that high calcium then triggers parathyroid hormone to go down. So high calcium, low parathyroid hormone may be caused by a lytic lesion.
Okay. Can you tell if a patient has cancer by looking at the PTHRP levels?
Yeah, great question. PTHRP is typically caused by tumors. It is not diagnostic, so it's not a screening tool for cancer. It's a way that we kind of identify the cause of the cause of the hypercalcemia. So high calcium level. If high calcium and the PTH is low, we just said bone tumor could be it, but a PTHRP, so a tumor secreting that PTH-like peptide, could do it as well. But it's not a way to diagnose a tumor. It's just a reason to look to find out where that tumor might be.
Okay. Parathyroid calcium issues. Do bone problems include teeth dental problems?
Yeah, great question. I don't know the answer to that. I'm not sure. Elizabeth, did you see anything about dental issues? I would imagine you could, but the teeth are probably last to go is my guess, but I'm not sure. The long bones, like, your arms, your legs, like I think that they're going to break down quicker, but yeah, I've not heard of anything with teeth.
Okay. Is hypothyroidism common in children or teenagers? I've only ever seen it in adults.
Yeah, it's much more common in adults. It can happen. We had discussed presenting congenital hypothyroidism, so a baby can be born with a dysfunctional thyroid. It's not very common, but it is one of the things that we screen newborns for. So when a baby's first born, they get a blood test. It's called a newborn screening test, and it actually looks at thyroid levels.
Okay. We had a question from Tylisha. Could high calcium cause osteoporosis?
High calcium cause osteoporosis? Not specifically, no. High calcium may suppress the PTH and kind of change some of that ratio, but it wouldn't necessarily cause the osteoporosis.
Okay. Could a low heart rate, usually lower than 60 beats per minute, be caused by a hormone imbalance?
Yeah, it's possible. We talked about hypothyroidism. So the thyroid hormone can increase the heart rate. So low thyroid can cause the heart rate to come down. So that is possible. It's probably not a common cause of low heart rate, but it certainly would be something I would think about, particularly if there were other symptoms of hypothyroidism.
Okay. Question here from Terry. Do you see relationships between rheumatoid arthritis, osteoporosis, and hormones?
Yes. One of the most common relationships between rheumatoid arthritis and osteoporosis is actually because of the cortisone. So if you're taking a cortisone type of medication like prednisone, suppressing your natural cortisol levels, causing bone breakdown because of that protein issue in the bones, then that actually is one of the most common medication causes of osteoporosis.
Okay. Great. We went through like 20 questions. Now is your time for a drink break if you need one. Great.
I'm sparing my junior partner these questions.
All right. Can PTU help anything else when using the medicine or just hyperthyroid?
Yeah. I don't know of other indications for the use of PTU, propylthiouracil. It prevents that transition from T3 to T4, T4 being the most effective of the thyroid hormones. But I don't know of other uses of that medication.
Okay. What macromolecules are hormones a part of?
Hormones can be proteins or fats, steroids. And so they're typically one or the other.
Okay. Does high cortisol dry out the skin?
Not specifically. It more causes thinning of the skin, as I'd mentioned, like the breakdown of the collagen within the skin. But I don't think of it as causing dryness of the skin. More likely to see skin dryness from hypothyroidism than cortisol.
Okay. I think this question is a little bit bigger than you, but why is it not normal to regularly or annually have blood tests to study our hormones and/or a full hormone panel?
That's a great question. It is a big question, and what typically when we think about just kind of screening blood tests, we have to be very careful on what we're doing with that information. So if we're looking for problems in a patient without symptoms, we're more likely to find something that would be called a false positive. So it's like giving us information that's not causing a problem. And so it's really not generally recommended to just screen people for everything, because then what happens is then you start looking for all these things that aren't really causing problems, and then people end up with procedures and studies and other things that may end up causing more harm than good because there wasn't a problem in the first place.
Okay. All right, a question from Amber. Could too much cortisol cause bruising that could lead to blood clots?
It can cause bruising. I don't think of it specifically causing blood clots.
Okay. Question from Katie, piggybacking off of a previous Zoom. For rheumatoid arthritis, a common treatment is long-term steroid for anti-inflammatory. How does that work with causing Cushing's? Is there other treatments, or would you have to choose of either the effects of rheumatoid arthritis or the Cushing's?
Yeah, that's a great question. There are, I think Dr. Verma talked in this series, earlier in the series, about rheumatology. Steroid medications are really a very, very important part of the treatment of rheumatic diseases like rheumatoid arthritis and lupus. But because of the side effects of steroid medications, most of these diseases, we look for steroid sparing regimens. So other medications that can reduce the effects of those diseases without the burden of all that steroid, for exactly the reasons we talked about with Cushing's, that if you chronically take long-term steroids, it can really cause so many problems in your body. Now, hopefully, if you keep the dose low, you only increase it when you really need it, you can avoid some of those problems. You have to be really, really thoughtful about it, but you have to be careful when you prescribe those medications.
Okay. Question from Jenna, can Cushing's syndrome affect your blood sugar levels, and why does it cause blindness?
Yeah, so Cushing's syndrome can affect your blood sugar levels. Yes. We mentioned Cushing's so cortisol increases glucose. However, if you have a completely normal functioning pancreas that makes insulin, it can usually manage that glucose level, usually. So that even though you have high sugar, you actually would have a high insulin that keeps the glucose levels down. So there's more sugar that's built, but then your body manages it. So the problem is, particularly people with diabetes, whose insulin is either not effective or not available, that's when you're really, really going to get into trouble with high sugar. As far as blindness, I wouldn't associate Cushing specifically with blindness, but high sugar can cause blindness because of blood vessel damage. So just anytime you think of diabetes and high blood sugar, just imagine that high sugar levels floating around in your blood vessels scars all those tiny little arteries, and the most vulnerable arteries are the arteries in your brain, so increase your risk for stroke. Arteries in your eye increase your risk for blindness. The arteries in your heart increase your risk for heart attacks, and the arteries in your kidneys increase your risk for kidney failure, and the arteries in your nerves and your skin increasing your risk for skin issues and neuropathy, so nerve breakdown.
Okay. Can cortisol play a role in PTSD?
Not specifically. PTSD is very complicated, and as we said, cortisol is a stress response. And so if you have high anxiety levels, then your sympathetic nervous system is more active, and you get more kind of stress response in your body. But it's not really a cause of like Cushing's or anything, because the feedback loops should still work. So if your cortisol level goes up, the ACTH will come down and the cortisol eventually comes down. So it's not really the stress and anxiety is not really a cause of like ultra high cortisol levels.
Okay. When the skin darkens, is it all over, or is it spotty and localized?
Yeah, yes, either way. It can be kind of spotty. I've seen patients who look really, really tan and they shouldn't be. It's in the middle of the winter and they're light-skinned people and they shouldn't be that tan. But I've also seen people with kind of spotty skin on the back of their hands in particular, or other sun-exposed areas, and particularly in the mucous membrane. So in the mouth, when you're examining somebody in the mouth, it can be very spotty in the mouth, on the lips, kind of spotty dark areas in the inside of the mouth as well. So it can be either. I think of sort of more of a diffuse tan skin and spottiness in the mouth, but it could be either way.
Okay. Question from Jennifer. Can the thyroid gland or related hormones be affected by the onset of perimenopause?
Not specifically. Again, your FSH and LH come from your pituitary gland. When your ovaries aren't working, those are kind of those levels actually go up, and could there be some change in the thyroid? I suppose there could be, but it's not really specifically related. What's more likely related is just kind of age association. So hypothyroidism is more common with people around that same age. So as people get into their 50s, it becomes more common. So I suspect there's more of an age correlation than a specific pathological correlation.
Okay. Can you explain the mechanism of action behind how high emotional stress in turn affects hormone levels and which ones, and then in turn can lead to chronic hypertension?
Yeah. Hypertension is extremely complicated. The sympathetic nervous system is a big driver of it. And as we mentioned, the sympathetic nervous system innervates the adrenal medulla and increases the epinephrine and the norepinephrine levels. The effect in the kidney and the RAS system gets kind of activated by the sympathetic nervous system. And so those kind of high stress levels do increase blood pressure that way. But high blood pressure is really complicated because, you know, even when the blood pressure is high, that should suppress all these systems, right? There should be feedback loops that suppress all these systems, but it doesn't always work. And so our modern lives have really created this. It's probably related to salt. It's probably, stress is certainly probably a factor in those things, but there's just something about our physiology that has allowed our blood pressures to get higher.
Okay. All right. Interesting question from Gabriella. Can hypothyroid affect fertility?
It can actually. So hypothyroidism is one of the things that you look for when people are having issues with conception, and that absolutely can affect fertility. So if somebody is getting a workup for infertility, they will absolutely be checked their TSH and their T4 level.
Okay. A question from Linda. If cancer enters your lymph nodes, what tests can show if it's spread further?
Yeah, it depends on the form of cancer. For people who've gone through some of these workups, they've certainly have heard of PET scans. PET scan is a way to look for kind of distant cancer spread. But unfortunately, cancer, depending on the type of cancer, can spread in such small amounts to different areas that you cannot always find it that way. And so you'll see patients who have cancer who maybe a PET scan doesn't show it, but then they get a biopsy of the lymph node that does show that there's cancer there. So very, very small amounts of cancer will not show up on scans.
Okay. All right. Forgive me if I butcher any of this. Can a parathyroid adenocarcinoma cause permanent loss of bone density or bone quality, even after surgical removal?
Yeah, it should be, you should be able to reverse it primarily. I don't know if there's much of a chance of permanent bone loss, but the problem is if you have such a severe bony disease from parathyroid disease, you can have fractures and deformities and everything that may not heal. The thing we didn't talk about is the interface of the kidney with the parathyroid, that sometimes when people have kidney failure, the calcium levels go down, the phosphorus levels go up, it affects the parathyroid, and those people can have really a lot of chronic bone problems as well. And so it's tied together, but for the most part, if it's an adenoma, it should be, I would imagine it should be reversible.
Okay. Question here from Diana. Is Graves necessary to be treated by meds? Will you have to go on meds in the future if you choose not to take them?
It is not necessary for meds. And as Elizabeth had pointed out, You can do surgery, you can do radiation, radioactive iodine. I mean, those are ways to treat Graves. The problem with that is that, remember, Elizabeth pointed out there's an antibody floating around that's triggering the thyroid gland. So if we effectively eliminate the thyroid gland, it doesn't eliminate that antibody. And so that's where thyroid eye disease can still be a problem. And so let's take out the thyroid, antibodies still floating around. People can still end up with problems with thyroid eye disease from that antibody. And so, so the answer is you can treat hyperthyroidism like Graves' disease without medication. But if there are other problems like thyroid eye disease, then medications may still be needed.
Okay, question here from Joshua. How does skin darkening present on naturally melanated skin?
Yeah, that's a great question. It's not as visible on naturally melanated skin. So people who naturally have dark skin, you may not notice the difference. That darkening of the creases on the hand can sometimes be more noticeable. They sometimes will notice, more darkening on the backs of their hands, like over the knuckles and that kind of thing. But that's where the mucous membrane darkening comes in. So it's possible that people who have naturally melanated dark skin may have a little bit of darkening, particularly around their gums, but should not really have it like in the back of their mouth. So if you start seeing like a lot of darkening in the back of the mouth, then that would be pretty telling that there's a concern. But that sign absolutely is much harder to interpret in people with very dark skin.
Okay, great. What causes cortisol to be lower upon awakening and higher in the evening?
Yeah, so it's actually the opposite. Your cortisol level should be high in the morning. That's the natural thing. Now, why would it reverse? Sleep-wake cycles are complicated. I don't know people who do swing shifts and things like that, if that kind of, will totally reverse some of those, natural cortisol surges. And if you're changing your cycle around, I would imagine that could get altered. But it should generally be highest when you first wake up.
Okay. Is there any downside to long-term use of levothyroxine or subclinical hypothyroxine? Any relationship between levothyroxine and osteoporosis?
Yeah, I don't think of anything as far as a relationship between levothyroxine and osteoporosis. Levothyroxine is a very common long-term medication, and we didn't specifically mention it, but when we just were talking about Graves' disease or other causes of hyperthyroidism, if you eliminate the thyroid, so if we treat it with radioactive iodine or surgery, then that means that you're committing that person to levothyroxine. But the nice thing about levothyroxine, once a day pill, even if you miss a dose because you're on a, you missed a day because you're on a trip or something like that, it's very forgiving. Like it's a really safe medication as long as you're monitoring those levels occasionally, making sure you're not too high or too low. But I really don't know the effect of osteoporosis. As long as your thyroid's controlled, I would imagine your bone health should be good.
Okay, this question is a little specific. If T4 level is normal, there are still low energy levels, weight gain, thinning hair, and high heart rate. Is there more testing to be done, or what should she check?
If the T4 level is normal and the TSH is low, you should check a T3. So even though T4 is the generally active hormone, T3 can be active as well. And there are some patients that will have T3 hyperthyroidism. It's very rare, extremely rare. Most of the time it's all going to be in that T4. But if I'm seeing that, if I'm really concerned that somebody could have hyperthyroidism and I'm not finding it on the T4, then I will check a T3 level.
Okay. Can Hashimoto's thyroid issues in kids be cured permanently? Do they have to take medicine throughout the endurance of their life?
Yeah, I mean, typically once you have hypothyroidism, you're committed to that for the rest of your life. I mean, it would be very unlikely that they would recover that thyroid function. And like I said, the good thing is it's a safe long-term medication.
Okay. Question from Emily. How do hormones change and how do they work differently in a woman who might be pregnant?
No, good question. That is a whole other talk. The everything's different when you're pregnant. Because the control, so when you're pregnant, the pituitary gland is really important. The placenta is important, the ovaries are important. You know, you need everything kind of working right. So even if you have hypothyroidism, that can affect your pregnancy. So the answer is yes, hormones are extremely important in pregnancy. Is not a quick answer, and I think that maybe we'll add that to the curriculum for next year.
Sounds good. How would growing nodules in the thyroid change the way the thyroid functions?
Maybe. So nodule could be hyperactive, so it could be creating hormone. It could be hypoactive, in which case, if the nodule isn't creating hormone, but the rest of the thyroid's working, that's fine. Or you get so much nodularity that it kind of just pushes out all the good tissue and you could get hypoactive. Most commonly, I think we had mentioned this earlier, most nodules are not active and the thyroid function remains normal despite the nodularity. But the second most common would be nodules that are hyperactive.
Okay. All right. Can allergy shot treatments cause any variation in hormones?
I don't think so. I wouldn't imagine that it should. I mean, allergy shots should be trying to manipulate the immune system to not react to allergens, but I don't think of anything that it would interfere with the hormones.
Okay. All right. Forgive me if I butcher this next one. Vasovagal syncope symptoms all involve changes in sodium, heart rate, and blood pressure. Does it relate to the pituitary adrenal feedback loop?
Yeah. The answer is vasovagal syncope is too quick for that loop. It's a very quick drop in the blood pressure that's related to the sympathetic and parasympathetic nervous system. That can work quickly, but the adrenal pituitary loop takes time to work. And so most commonly, it's not related to it. Now, if you have problems with, say, hypoaldosteronism, you're going to be more prone to it. So your starting point is going to be lower. Your blood pressure may already sit a little bit lower. You may have a tendency towards kind of low blood pressures that it's easier to go into a vasovagal syncope, but it's not necessarily the specific cause of the vasovagal syncope.
Okay. Thank you very much. Can reverse T4 or reverse T3 levels trigger hypothyroidism?
I would defer that question to an endocrinologist. I think that that would be something that I would just be guessing.
Okay. A question here from Amy. Should anyone with an autoimmune disease consider an endocrinologist as a regular doctor?
Not necessarily. I think autoimmune diseases are so diverse that I wouldn't be able to say that. However, as we mentioned, since autoimmune diseases often run together, if you have one autoimmune disease, it's worthwhile looking for those. But if there's no signs of those, I don't think an endocrinologist would be needed.
Okay. How quickly can pituitary tumors develop and why do they develop?
Great question. So pituitary adenomas, we mentioned, typically are not cancer, but they can produce hormones. It can take years for them to develop. And actually, the most often situation is that there is a pituitary adenoma that isn't doing anything, or an adrenal adenoma that isn't doing anything. That's just like this cluster of a cluster of cells there that's forming this tumor, but is not creating hormones. So that's actually probably more common than a tumor that's creating hormone. Pituitary adenomas can create different hormones. You can create prolactin, it can create ACTH, it can create TSH. Like there's a lot of different things, or it could create multiple hormones as well. As far as how long they take to develop, probably years. I mean, that would be the most likely answer. I mean, they're slow growing tumors. The problem with the pituitary is it's a very constrained space, though. because there's bone all around it in the base of the skull there, that it doesn't take a very large tumor to really start causing problems.
Okay, great. Are there any populations that are more susceptible to developing a thyroid disease, especially in children, such as children with Down syndrome?
Yes, I don't remember specifically about the connection with Down syndrome or trisomy 21 and thyroid disease. That wouldn't surprise me, but I don't remember it specifically. As far as other populations, like we mentioned, other autoimmune diseases. So if you have, multiple autoimmune diseases are more likely. Women are actually a little bit more likely than men and in adults, but I believe that's probably true in kids as well. There may be other connections, but I would not specifically associate with Downs, but I'm not sure of that one.
Okay, thank you. And as we're approaching 2 minutes, we have one last question from our attendees. This is from Amy. How do hormones play a role in hair growth and nail growth?
Yeah, great question. I don't have a great answer for that. We talked about hypothyroidism. You can get hair loss from it. You can get skin dryness. We talked about cortisol and the effect that has on the skin. I don't exactly know physiologically what the effect of those hormones are within the hair tissue.
Okay, great. Thank you. Since we have 1 minute left, there is an opportunity for any last minute questions. If any students on the call have any. If not, we want to thank everybody for their time. Thank you for the wonderful presentation, doctors. We were pleased to have you. I'm sure the students are going to be taking away a lot from this presentation.
All right, I hope so. We had fun making it up, and like I said, it was a pleasure to partner with Elizabeth, and I hope we're able to give a little insight into the way that we learned some of these health problems, so that you all can see what it really is like to be in the mini medical school.
All righty. Well, thank you very much, doctors and colleagues from Sussex County Health Coalition. Next week, we're going to be talking about sports medicine, dance fitness, and sports medicine with Dr. Elizabeth Barchi. Have a good night, everyone.
Thanks, everybody.